Thank you. So can you see my screen?
Yes.
Okay, good. So this would be our, it's just a brief session outline. First, the introduction, and thank you so much for joining. Then we will have a brief discussion about the screening and identification of malnutrition in a child with cerebral palsy. And Dr. Mercedes Ruiz Brunner from Argentina will be talking about that uh, with you all. So feel free to join in the discussion. And if you have any question, please leave comments. Then we will have a brief time for Q&A. Then again, we will have another brief presentation from my end about prevention and control of malnutrition among children with CP in LMICs. And finally, again, we will have some question and answer session and then closing remarks. Now, I will hand it over to Mercedes. Mercedes, please feel free to start.
Yes, here. Okay. So I will start with this first part of the webinar. My name is Mercedes Ruiz Brunner. As Israt already said, I'm from Argentina. I'm here now. And I'm coordinating the Argentinian CP register and the Latin American CP register. We're going to talk different topics about screening and identification of malnutrition in children with cerebral palsy. And the first one is, what anthropometric measure should I take? This is one of the most frequent questions that we usually have. And the first thing we have to know is the instrument that we have to have a proper anthropometric evaluation. We need to measure weight, height, circumferences, just like middle upper arm circumference, skin folds, and segments, body segments like knee height. These all are low-cost instruments that we can all have in our practice. We will talk a bit more about scales that sometimes are one of the challenges. The challenges in CP, when we are talking about anthropometric measurements, one is for height, is with bone deformities that complicate the measurements. The bone deformities in the legs or in other parts of the body usually complicates the measurements. Another thing is regarding to weight, that sometimes when we have small children, we can have them pick them up and measure and weight with them in the scale. But when they are older or bigger, we need a wheelchair scale, and most of them we don't have access to them in our context. The other challenge is that skin folds are not frequently measured, and these are very important for us to know the body composition, and we will talk more about that in our presentation. When we have the measurements, we can have two types of methods to have the measurements. One are the direct methods, and one are the indirect methods. And we should know that the characteristics of each one are very different. When we talk about direct methods, is, for example, when we have weight, so a person is on the scale and we have the weight, the height, or the body segments. These are direct measurements. We compare them with reference patterns according to the age or sex, the growth charts. It should always be evaluated in the same way with the same instruments. Sometimes there are differences between the scales, for example, and we should measure them in the same with the same instruments. And also, it is an accurate value if they are taken without difficulties. When we measure height, for example, and we have a lot of bone deformities, now the value is not that accurate as we should imagine. So in these cases, we should know that we are not having the exact same or the most accurate value. When we talk about indirect methods, for example, these are estimated anthropometric measurements. Sometimes we have them through equations or instruments to evaluate as close as possible, but it is is a value that is approximated. It's not the exact measurement. They present errors that we cannot control, and sometimes we don't know if we have the close value or not, and we don't know the precision in each case. We should not take this as a direct method. We should know, and when we, for example, write it down in the clinical history, we should write that we got this weight, for example, from an equation, an estimation equation, or that we have complications measuring height, for example. It should be explained in the clinical history what type of method we use to obtain the anthropometric measurement. We have these direct methods that are always the best option and the first option that we should consider. When we have weight, we have direct from scale. The child is up on the scale. This is the most common, but is the less frequent in cerebral palsy because it's very difficult for a child to stand sometimes in a small scale. We can also use this weight that a parent pick up a children, and then we discount the weight of the parent, of the caregiver, and then we have the wheelchair scale that is also a good option. We use a lot the wheelchair scale also for children that are not in wheelchair, but they don't have a lot of stability, and sometimes they sit in the scale, or we put a chair in the scale and a regular chair, and they sit. So sometimes it's a good option, but it's an expensive option, and sometimes we don't have it in all the consultations. When we measure height, the regular weight is standing, but in children with CP, sometimes it's difficult to measure. So it's also possible to measure a reconvert height that could be measured even in children older than 2 years old. We have also body segments that the ones that we should always try to measure are middle upper arm circumference and knee height. We're going to talk a bit more, but we should always measure them in the regular practice. Indirect measurements are, for example, for weight or height, the estimation equations that we are going to talk a bit more in the presentation, and also body fat that usually we obtain it for indirect measurements for bioimpedance or even equations that we are going to talk that are really good and easy to obtain. But we also need to use them with caution. We should the thing is to know that they can have not the exact value, and we should always write it down when we do these indirect measurements. When we talk about equations to estimate height, one of the most known equations is the one published by Stevenson in 1995. This is an equation. They have 3 different equations. This is the one with the information for the knee height. The thing that is important to know that this equation is up to 12 years of age. It's designed to be for children younger than 12 years old, and usually the most difficult times to measure height is in older children. So we know that when we are estimating height in children older than 12 years old, sometimes this equation is not really precise. Also, this year, we published a new equation that considers EMF levels, because we saw that this is the one from Stevenson is the same equation for any gender or any GMF level. We evaluated the GMF levels really matters, and it's different the growth in children between level 1 to 3 and level 4 and 5 of GMS. So we designed two different equations that you can use. And also we saw that to give more precision to the equation, we need to add age into the equation. So we put the number also of age in years. It doesn't matter exact month, it's just to give more precision to the equation. So we put the knee height value and the age. We do this equation and they give us the value. According to the GMF level, we choose which equation we should use. And we saw also that gender or sex, it wasn't really a difference in children with CP, while in children with typical development, it's important to consider gender. In children with CP, it's more important to consider GMF level. We also published in 2021 an equation to estimate weight. This equation used the middle upper arm circumference because this is a measurement that takes also bone, body fat, and muscle into account, and is similar to what weight takes into account. And also we have one equation for each GMF level group, and also we should add age in years to consider more precision to the equation. So these are easy equations to estimate weight. Also, we have, you can access through this QR code. We have in our webpage, you can calculate the estimation weight or height, put in all the numbers. You should only choose the GMF level and then put the knee height or the middle upper arm circumference and the age, and you can calculate the estimation value. This is the same as applying the equation, the full equation. You can do it also with the calculator, but this is a much easier way to calculate them. Also, there was a publication in 2022 that was a toolkit for health professionals to do nutritional assessment. And they explained that when you want to assess weight, for example, in children that can't stand still, you can use a digital scale available. And if you don't have a digital scale, you can go through their recent information or ask to different health professionals. When you have children that they cannot stand still, you can use a wheelchair scale, or if you don't have available, you can use our equations to estimate weight. Also, you can use the weight in the arms of a caregiver if it's a small child that you can lift up. I don't know if someone have a question?
Not yet.
Okay.
Yeah.
Another thing is that for me, sometimes they ask about the equations because we work on them, but I will always try to tell them when to use the weight and height estimation equation and to know really what makes the equation more or less accurate. So we can do a proper use of these equations. Oh, sorry. Weight equations and height equations, the estimated equations, are meant to be used in population-based, are meant to be used in a group of population and not in an individual children. This is because when you use in a population-based, the errors are less are less. You have more population and the chances of having an error is less. But when you use it individually, we don't know if the estimated measure is close or not to the real weight. The same happens with height. You don't know if it's really real or not. And this was a concern for us because we said, okay, we have the estimation, the weight equation. So what should we, how do we know if they are precise or not? Can we estimate or know something that makes us like an alert for us to use or not to use, or have like caution when using. And this is when we did this publication with ISRAD and Gulam's group about the implementation of the equations in a group of children from Bangladesh. We implement the same equation that we have in children in Argentina, and we use it in children from Bangladesh. And when we evaluated what makes it more accurate or less accurate, we saw that it depends on the malnutrition. When we see it here in this chart, in the first chart, figure, sorry, we can see that when we have children that have a set score higher than minus 3.99, that is still malnutrition. But when we have them, the observed weight and the estimated weight are very close one to the other. But when we have children that have a set score from weight, height, or body mass index lower than -4, we can see that the estimated values is most in children, in adolescents and teenagers, are less accurate. And we can see that the estimated value usually is higher from the observed value. Yes, the estimation equation tries to take the value higher than it really is. So those children with set score lower than -4 will have less accurate weight estimation. And we should know that the precision of the equation is less. And why happens this? Because when we see the normal bell shape of a curve cut into set score, we can see that most of the children should go between -2 and 2, and the values -4 is far away from the normal distribution. So the equations use the data, is it worth more normal distribution? But when it's -4, is a really strange value or really abnormal value, and the equation doesn't work this well. So, but you will ask me, how do we know if the children, he or she has a set score -4, if I can have the weight of the children? This is one of the complications. And the answer is to have a physical exam for severe undernutrition and look for signs for clinical undernutrition. We can see that usually children with severe undernutrition, and I think that this evaluation should always be done, are usually having more bones that are visible in the chest, in the back, in the arms and legs. So when we see these bones that are more visible, we can see that they have a severe undernutrition, and we know that if we use the equation, the value that we obtain, it will be a little bit more higher than it's really going on. Another thing is only weight and height matters. So I focus a lot of how to estimate the height and how to estimate weight, but it's not only these are not the only values that we should be taking into account when we do a nutritional assessment. The EFCAN in 2017, they do a lot of recommendation about nutritional complications in children with neurological impairment. I suggest you to read this paper because it has a lot of information. And they recommend that the assessment of nutritional status in children with a neurological impairment, like CP, should not be assessed solely on weight and height measurements, and recommend that the measurement of fat mass by skin fold thickness should be a routine component of the nutritional assessment in this group of children. So, but usually body mass or fat mass index are not into the clinical practice or the regular practice, but I encourage you to do it at least once a year. And if they are in treatment of malnutrition, we should do a more regular follow-up. So when we analyze the body fat mass in children with CP, there are significant numbers of children with excess fat who have normal weight. And even we saw children with undernutrition that have an excess of fat. We should implement no methods to identify excess fat and combine them with tools to measure healthy mobility, function, and well-being. So we're trying to know the body composition in children with undernutrition here in Argentina. We are working on this. We are working on DEXA scans, as you can see in the pictures, but we are also taking skin fold measurements. We saw that although the children with CP presented undernutrition, they present body fat that is percentage that is elevated. So we can see, for example, in these children that he has, for example, body index Z-score for age Z-score that is -4, and he has a chronic undernutrition, and still the body fat tissue is around 29%, and it should be around 19%. So it's a higher percentage, also a higher percentage in the legs. Still, we need to study a lot more than what is the expected body fat measurement or tissue, body fat tissue in children with CP, because probably it's different than other children's, and as the leg does not move regularly or as typical development children, probably they will have more body mass in the legs or in other parts of the body, and we should study a bit more, but it's interesting to know that the percentage of body fat is not the same as we expected. But usually we don't have access to a DEXA scan. It's an expensive study and not always having access to them. So how can we measure body fat? And here comes the skin folds. Skin folds are something easy and cheap to measure.
I think we are having a bit internet issue. Let's wait for a few minutes. Mercedes, we lost you
Yes.
for a few minutes. Can you go back to the previous slide and kindly explain?
This one? Sorry.
Yes. No, the skin fold. Yeah.
Okay, so here, skin folds.
Thank you.
So the measure of the skin fold is something that is easy to have, and this is the step one, and we should measure these two skin folds, subscapular and tricep. These are the most important, the most important that, or the ones that we are going to use to estimate body fats. Once we have the skin fold, we will apply this Gurka equation that is really precise. In previous study, it showed a 95% of exactitude compared to a DEXA scan, so it's really easy to measurement. We have to have the skin fold, and we have to know the Tanner stage of the children. That is another important data that we should have in regular clinical practice. So it depends on the sum when we add tricep and subscapular information number or data. We know if it's less than 35 millimeters, we should choose from one of these equations, and if it's higher than 35 millimeter, we should choose from one of these equations. Once we have chosen the equation, then we do the correction for all children with CP. We add 12.2, and then they have additional correction for males, more severe GMF levels, black race, pubescent, post-pubescent children, and children with skin fold higher than 35 millimeters. So we do all the corrections, and we will have the measurements. We can use for measure the skin folds, we can use this equipment that sometimes are a bit more expensive, are these Carpenter or skin fold measurements that are a bit more complicated, but also we can use the plastic ones, having shown really good results. They are easy to take. They have less long life because sometimes they break, or they can yes, they can break. So sometimes they don't live longer, but they are really cheap, and they are easy to transport and everything. So it's a good option to measure skid falls. This is, I think, one of the most debatable and frequent question, that is, what growth charts are used to for nutritional diagnosis in children with CP, and why? Do we use the US CP growth charts, or do we use WHO growth charts? And this is one of the most frequent questions. We can see that prevalence of undernutrition is higher in Latin America compared to high-income countries. We can see that in Latin America, for example, half of the children have undernutrition, while in higher income countries, 3 of every 10 children. And this is similar in other low and middle income countries. In Asia or Africa, undernutrition is very frequent problem, but we should know that just because they have CP does not mean that they must have malnutrition. In other populations, in Australia, for example, not all the children with CP have undernutrition. So there are other things going on that leads to undernutrition in our countries. We have these 2 groups of growth chart from children with typical development, like CDC or WHO growth chart, and growth chart from children with CP. I always try to use the from children, not for children, because they came from data. Growth chart from children with typical development, they show the expected growth for children to be healthy. All the children that were included in this growth chart, they shown some criteria to be healthy, to be considered healthy, to be added into these growth charts. They have cutoff point for anthropometric diagnosis. They allow international comparison between populations. WHO growth charts are based on an international population, so they have children from different countries. But the difficulty with this chart is they don't present weight for all children, for all ages. They present weight for height just until the age of 10. It is recommended to use in set score because it has more statistical precision and not in percentiles, and should be used in children with CP also. A child with CP can reach normal values that are higher than minus 1.99 set score. Maybe they are not going to the 0 set score or percentile 50, but they can reach the normal range of values of what is expected. So these are the charts that are recommended. These are the diagnosis cutoff points that we should consider when we have, these are from the WHO's training manuals that are really interesting to have and read. So I recommend it. So we will diagnose the children to be stunned, underweight, waist, and severely waist and underweight of stunned. And why I said that we should use percentile instead of set score? When we measure a children here with percentiles, we can see that he's lower than the 3rd percentile. So we will consider him or her with undernutrition. I don't remember if it's a boy or a girl. But if we do the same evaluation, anthropometric evaluation with the set score, we can see that he was severely underweight, and now he's underweight. So the 3rd percentile is related or closer to the -2 set score, and the -3 set scores give us the level of severe undernutrition or severe underweight. So it's important to value with set score to have a more precise underweight or malnourished diagnosis. The growth charts from children with CP are a growth chart that they were taken from children with the US, from database from children with from the US. They describe the growth of other children with CP. Many of them were having malnutrition. So they were not a criteria to enter the study. They used all the data set that they had in the clinical histories. Even data from the 80s, so they didn't really know if the height was taken properly or not. The weight, they know that it was okay because they had proper scales for that, but they only describe the growth of children with CP. In weight for age, something that is really valued is that in weight for age, they have a risk zone of a higher morbid mortality, that is this red zone that we can see here in the chart. They are useful to explain to family that beyond the CP, their weight is very low and dangerous and is in a risk zone that can lead to more complicated. And other children with CP can be out of that red zone. They can be used to choose another feeding route or option or nutritional reinforcement, but they are not for nutritional diagnosis. They don't have the cut-off point to have a nutritional diagnosis. And this is important to know. They only describe growth, and they have this red zone for higher risk for morbid mortality. They can be used as a complementary measure, especially in the children with more severe motor compromise, GMF level 3 to 5. They come, these charts are the ones published from Brooks in 2011, and they come in different color for boys and girls and different GMF levels. But they are meant to be used with caution, I like to say. Depending on the GMF level, this risk of mortality or this red zone could be in GMF levels 1, 2, and 2 under the percentile 5. And in children with GMF level 3 to 5, the red zone is close to percentile 25. So if we use the children with CP in this growth chart under the percentile 5 are with undernutrition, we'll be doing a wrong diagnosis in more severe cases because we cannot use percentile 5 as a cutoff point. They don't have a cutoff point for what is undernutrition, stand, or waste. So we can use them and know that they are in this higher risk zone. So for example, in this child, we can see the weight that started at age 8 was close to percentile 25, but then started to be lower and enter the risk zone. What should we do in this case? We should change. If they are not in a nutritional treatment, we should include them for sure. And if they are having a nutritional treatment, we should think of changing that nutritional treatment. Maybe adding some enteral nutrition support or having another oral feed, another feeding form like tube fed. For example, we should see in each case of the children, but we should know that something in the nutrition of these children is not going well, and we should be doing something to take the weight or to be for them to having a higher weight. Where is the weight risk zone in typical development growth chart? This was one of my questions, and I was thinking, where are the risk zones? We put it all together in the typical development growth chart. So I entered them into the Anthro from WHO's growth chart. And we can see that in children with GMF level 1, this risk zone is very close to -3 set scores. And in children with that are orally fed in GMF level 5, that is the lowest of the risk zones, we can see that is also under -3 set scores. So we can assume and use sometimes these typical development growth charts and know that the lower the set score, the higher the risk of morbid mortality. So we know that if a child has -4 set score, probably the risk of morbid mortality is higher than if they were -2. But it's also important to look through the time, evaluate the growth trajectory or trend, not an isolated point. For example, in these children, if we do an isolating point, we can see that he has a normal nutritional status, right? But if we see the trajectory, we will see that he is in a risk of nutrition because at this point, he has some flattering and he's changing the set scores values that he usually had. So this is a risk of nutrition when you change the trajectory. So it's important to measure through time. Usually we said that we should have at least 3 or 4 measurements to really do a nutritional assessment. Flattering weight and or failure to thrive is a sign of undernutrition. For example, we can see that here flattering is a risk of undernutrition, even when it is under -2 or when it's higher than -2 set score. We can see also that these children have some flattering in their growth, and this is a risk of undernutrition too, even though the values are normal. And one of the last question is, how often should we do nutrition and should nutritional status be monitored? And children with disability, this is from the ESCAN recommendation, must have anthropometry measurements at least every 6 months and micronutrients monitored annually. This is for children with disability without any nutritional problem. So at least 2 times a year, we should at least every six months, we should do a follow-up of undernutrition, and we should have more frequent controls when malnutrition is observed. Children with undernutrition should be monitored more frequently. As a take-home measurements, what we should be including in a screening for malnutrition in children with CP is a complete anthropometric evaluation that include body segments and include body fat percentage. We should evaluate growth over time, use WHO or typical development. We can use also CDC growth charts, or we can use our local growth chart patterns, but the ones that are measured for meant to be from children with typical development. We should focus on preventing undernutrition, pay a lot of attention to flattering. It's easier to prevent undernutrition than to treat undernutrition. And we should increase nutritional follow-up of those children with severe motor compromise. We have seen that GMFCS level really matters, and children with higher GMS level are had higher risk for undernutrition. So children with GMF level 3 to 5 should be analyzed and also see the risk zones. We can use the risk zones from USCP growth charts. So thank you, everyone. I will open the Q&A space, and here a picture of some of my colleagues that are also working with us in the CP registers, in the local CP registers.
Thank you so much, Mercedes, for this amazing presentation. Very informative and very important in terms of identifying malnutrition in children with cerebral palsy. We have already a few questions on the chat box. I'm going to read aloud. The
Okay.
first question was from Binte. Please apologies if I pronounce your name incorrectly. Sorry about that. So Binte asked about how do you look at hanging scales? We use them till 15 kilogram.
If they are precise, they can be used as long as the child doesn't it's not risky for the child, they can be used. But with all scales, we should always see if they are giving precise values. So we should take something that we know their weight. For example, some weights like from training wheels or something that we know exactly the weight, and use them in the scale and see if they are precise or not, to check on them.
So is there any upper limit on like to till how much kilogram should be measured? Or is there any age limit you would suggest? I think Binta's point was that like they use till 15 kilogram weight.
In
Yeah.
hanging scales, it
Yes.
depends on the hanging scales. Not all
Okay.
of them are the same,
Okay.
because there
All
are
right.
some of them that are really big and meant to for even for older elderly, and there are sometimes the ones that are usually smaller. We usually use it between 10 or 15 kilos.
Okay. Yeah. All right. Then the next question is from Pamela. At what age can we use a bioimpedance device?
More than the age, it's difficult to use them in children with CP sometimes because they cannot hang to the, if we have the ones that are in hand, or they have to stay still in the scale. Sometimes it's difficult for them to do that. So sometimes it's not the age. Some devices are meant to be up to 2 or 4 years old, but sometimes we have children with 15 years old that we cannot do have them hanging for a long time from a measurement, a impedance measurement. So it's really difficult. Usually we use more the skin folds and the Gurkha's equation more than bioimpedance.
All right. Thank you. And there's the last question from Biloti Mercedes. And the question is, to perform anthropometry in people without CP, the person is placed in an anatomical position. Are there any considerations about this in people with CP?
Usually we try to do anthropometry when in the moment that the children is more relaxed. So if we are doing it in the rehabilitation center, usually we do it after the physiotherapy. So they have more relaxed, and we do it in a bed or something that they can lay down to take the high measurement, for example. But we are meant to use it or do it in the moment that they have the muscle more relaxed. That's the most for the when the children have to measure height. Because when we use a scale, fortunately we have the wheelchair scale, so we use that. So they only have to stand there, so it's not very difficult.
I hope that answers your question. Viloti actually asked another question, which is, can spectrometry devices such as oligocheck, etc., which are used on the hand, be used?
Yes, yes, they can be used, but sometimes it's not easy to use them or not available. So in this presentation, I try to focus on the ones that are more available to be used in children with CP. Here, there's another from Aaron. I'm seeing that children with CP often suffer chronic malnutrition despite constant supplement feeding. How can this be addressed? Okay, so we should do another webinar about the treatment of malnutrition, because this was only for screening. Still, there's a lot of things that we are missing. In this case, we should also look if we have another physiological things going on, like parasites, or if there's an intolerance to some feeding, or if they are celiac or something like that is going on, to see, because usually if we are supplementing the correct amount of kilocalories that they should be having, they should be increasing their weight. Maybe not as fast as we should think or want, but they should be having an increasing on weight.
Yeah. The other thing is, Aaron and Mercedes, please comment on that. The other thing is which indicator we are using to identify chronic malnutrition, because the most commonly used indicator is weight for height. And as Mercedes has explained, height has not been a very good indicator reflecting nutritional status. So, like, to be pragmatic a little bit, we use weight for age and MOAC and skin fold thickness to see whether the child is progressing. And if you look at the pattern after three consequent measurements that the child is still going down, then there is definitely a concern. And if there is any clinical indication of malnutrition, then definitely that child needs special attention. But if you see that it's progressing, then I think sometimes chronic malnutrition, like explaining chronic malnutrition in children with CP would be, like as Mercedes said, we would need another webinar to focus on that
and
topic.
Sometimes half kilo in 6 months increase is a lot. So because sometimes these children have not increased their weight in 2 or 3 years. So having only half kilo increase or 1 kilo increase is an improvement of their nutrition. So sometimes it's small differences, but this should all be taken into account. And the last question, and then I will let Isra with her part.
It's okay. It's a very interesting conversation.
Do children with CP have higher need of micronutrients? And this, in all the studies, they have shown that they have not a higher need of micronutrients. They do have sometimes less consume of them. Usually they don't reach all the minimum consume of micronutrients. So we should follow and do a follow-up of what they are eating, what they're having, and also do blood test analysis to see if they have a deficiency of any micronutrients. For example, vitamin D, should we follow up for anemia and different micronutrients? In the EFCAN document that I show you from 2017, they have a lot of recommendation of micronutrients and what should we be taking into consideration.
Thank you, Mercedes. One final question from my end. As you are aware, and as you have explained, that anthropometric measurements are more commonly used in low and middle income countries in our settings, like especially when we are working with the community-based program. Now, the measurement error is usually very high if you are not trained well. So would you be interested in running any online training on how accurately to measure collect different anthropometric measurements and how to read growth charts? And as you have explained, for our audience, if they have interest in the future, then we can definitely reach. Yeah. All right.
Yes,
awesome.
We can do something like that if you want, if it will be useful for everyone.
Yes, I think that would be very useful. Dear participants, please feel free to share your interest, and we will be reaching out to you with once we have some more information about this. But I think that would be very, very helpful. Yeah. All right. Thank you so much, Mercedes. I think if no one has any other question, then I would like to move to the next presentation. I will try my best to make it on time. All right, let me share my screen. There you go. Can you see my screen?
Yes, we can.
Perfect. As Mercedes has already described how to identify a child with malnutrition, child with CP suffering from malnutrition, then the next question comes, now what? What do we do? Once we have identified malnourished children, then how to manage that situation and like complications from malnutrition, as well as how to prevent future any adverse outcome for these vulnerable kids. So before moving forward, I would like to, I tried to use Menti, but obviously I failed. So, but please feel free to unmute yourself or text on the chat box. My question is, how often do you see malnourished children in your routine practice? Can anyone please comment? All right. Unmute. No.
I see it. I see it. Hi, good morning. Thank you for your nourishing presentations, first of all. I usually see it practically every day because I work in a public hospital. So we see it every day since we receive the people that have a low income. So we see it almost every day, and very bad education for them.
Yeah. So I agree, Pamela. Malnutrition is very, very common among children with cerebral palsy. And I think in LMICs, with the resource limitations, with the other socio-demographic determinants, the condition is much poor. Now, I ask this question because, as Mercedes mentioned earlier, regarding the high burden of malnutrition in Argentina, we also did a similar study in a few years back, where we used the data from the global LMIC Cerebral Palsy Register and compared information from Bangladesh, Nepal, Indonesia, and Ghana. Now, if you look at this chart, these dotted lines are from DHS, Demographic and Health Survey. So these are the national data. And then these black line are for people, for children with cerebral palsy registered into those country-specific CP registers. And you can see that the difference between the severe malnutrition rate, -3 to -5Z, is quite high for children with CP in all those countries. All those countries. So that's a very major concern, obviously, because as the dietitians and all of us know, that managing a child with like normal nutrition or preventing malnutrition would be much easier than treating a child with those severe malnutrition. Unfortunately, we see this very commonly in our cohort. Now, what do? We have to address those, right? We have to do something. So, okay, something happened. Yeah. So we did a scoping review a few years ago, like in 2022, I think, where we looked into what evidence are there for nutrition intervention for children with cerebral palsy in low and middle-income countries. And not very surprisingly, we found only 8 articles after screening through over 16,000 articles. So only 8 articles actually met the inclusion criteria and were from LMICs describing different intervention outcomes. Of those 8 studies, only 5 focused on dietary modification and 3 on feeding skills. And the common finding was that dietary modifications and training on feeding skill actually could improve the nutritional status of children with CP in LMICs. And we also did, there was another publication from Rebello et al., and they did a global review, and very surprisingly and similar finding is there were only 1 study included from LMIC. So you can imagine the lack of information from low and middle-income countries. Now, in this setting with such high burden and then almost non-existent evidence of different intervention program, whether that work or does not work, we would definitely have to rely on whatever evidence are available from high-income cities. But as you understand, as we all have been discussing, managing malnutrition could be very complicated in children with CP. Now, I think many of you have seen this conceptual framework of malnutrition. This was developed in 1990s by UNICEF and WHO and has been supporting many nutrition intervention programs to date. So when I like this framework very much because it fits, it represents all aspects of malnutrition, not only focusing on the immediate causes, but it also talks about the underlying causes and basic causes. So when you are treating malnutrition, there is a need, especially in LMICs, to emphasize on all these aspects rather than just the immediate causes. In addition to that conceptual framework, we, as part of my PhD, we also developed, it's not like a framework, but it's kind of a summary of the findings from GLM-CPR epidemiological data. And we drew a diagram to trying to understand which factors actually increases the risk of malnutrition in children with CP. And as you can see, that the clinical characteristics, motor severity, and dysphagia, these are all very significant predictors of malnutrition in children with CP. Now, we also found that with increasing age, being a female children, then children whose mothers had low education, also children whose fathers had low education, they were more prone to malnutrition. Now, these two diagrams basically defines that when we are planning for a program or intervention to prevent and control malnutrition, it's not the dietary intake only, it's not the addressing the clinical needs only. It has to be a whole comprehensive program so that otherwise the child will return to the previous, like maybe with immediate treatment, the child would improve, but then once returned to the community without a sustainable plan, then the child will return to the red flag zone again. Now, unfortunately, our evidence from LMICs mostly focus on these three groups, the immediate causes, not from only LMICs, especially in high-income countries as well. The research being done so far has focused on dietary intake, what feeding formula, what enteral feeding, which method, surgical or not non-surgical, would improve nutritional status of children with CP. But what about all these factors? We need evidence from, especially for LMIC setting, to address the inadequate dietary intake and disease pattern. I will talk a little bit more about in the subsequent slides, but yeah, so this is just a brief. Okay. Now, Mercedes has already shared a little bit about ESPGHAN, and I agree with Mercedes. Please read these materials. These are very, very informative and very specific. So very helpful for us when we don't have any evidence from LMICs. So the first one, the recommendations for nutritional management. Let me just get a pointer maybe. Yeah, the first one, this actually talks about the overall requirement, how to manage in terms of requirements, what aspects, clinical diseases and other needs to be reviewed when planning dietary intake or nutritional management plan for a child with CP. Then not neurological impairment, but they talk about CP a lot as well. Then there is this guideline, the dietary management of children with neurological impairments. They go a bit more intensive, like depth, and they talk about the requirements and modifications, which formula to use, how to select formula for formula feeding and all this stuff. Now, these are more updated guidelines from the community, but I also like this paper very much because it's kind of a summary of all the available evidence on nutritional management of children with CP. Now, all these basically summarizes the key recommendations from all those resources are like, first of all, oral feeding is preferred. However, enteral feeding should be started if the oral feeding duration exceeds 3 hours per day. Just to give a minute. Sorry. Sorry. Anyway, so oral feeding is preferred, of course, and then, but when talking about dietary composition, because children, as Mercedes was talking about, that the body composition of children with CP varies and the requirements would vary, then therefore the dietary composition should be like they recommend that the dietary composition should be discussed with the dietitian before initiating and others. Then they talked about a lot about energy requirement. So in terms of energy, protein, vitamin, micronutrients, and fiber, the first go-to recommendation is it's similar as children without CP. However, depending on the mobility, muscle tone, severity of motor impairment, and all these aspects, these requirements may change. So, sorry, I'm having some internet issues. Can you hear me still?
Yes, we can hear you good.
Okay, good. Thank you. Okay, so it's raining outside. It's not my fault. Anyway, so for children, like for infants, they suggest that use the standard infant formula. For children older than 1 year, they suggest that there should be like standard polymeric age-appropriate formulas should be used. And for children who needs catch-up growth, there is an increased need for energy as well. And as you can see, they recommend use of high energy dense formula for children who has poor volume tolerance, like because of the gastrointestinal reflux and other clinical complications associated with cerebral palsy. Continuing the recommendations, fiber requirements similar as children with CP, children without CP, micronutrients similar, and hydration similar. What I would do is I will share these materials with you all once, or can share this link after this completion of this webinar. Now, looking at this guideline, and okay, so they also recommend this flow diagram, like how to select which method to follow for feeding and intervention. And as you can see, it's quite straightforward and very nicely summarized, and when to use tube feeding and when to use gastrostomy or genstomy and other surgical methods. Now, my question to you would be, in LMIC setting, how feasible do you think it is, and how could be, like, what could be the potential challenges in implementing those recommendations in your local settings? Any thoughts? None? People are tired? All right, let's move forward. I will share my opinion then. So I love this flow diagram very much, and it's very useful. And I tried to adapt it in a few of my program that I'm working on. Sorry, excuse me, please.
They're putting some information in the chat. For example, parent resistance, money. Bennett said that in our setting in Malawi, caregivers can't pay for formula an extra dietary food if it's available, an extra special food.
Yeah, thank you so much. Thank you. Thank you. Exactly. So although we have these beautiful diagram, there are so many social health determinants that we need to consider. And you actually summarized my next few thoughts. For example, how do we decide whether the swallowing is safe or unsafe? Do we have the human resource trained, or do we have the equipment and access to the advanced technology to actually confirm whether a child should be fed orally or tube feeding should be started? Sorry, I'm doing the webinar from my home, and I have a big family. Anyway, so then Then the other thing is, when there is an unsafe like feeding, if it is identified that the feeding is not safe, then how, like, whether it is because of not the correct consistency use, or is it because of the positioning issue, or what's the main reason? How do we decide that? How do we identify those issues? Then the third issue I find is like, tube feeding is definitely the best option for, especially for children with severe dysphagia, and oral feeding is not safe. But is it feasible in community-based settings in low and middle income countries? In Bangladesh, it is not. We can do in rehabilitation, institutional rehabilitation setting, but in community-based setting, I don't think we can actually scale it up, this program, not only because of stigma, but also because of maintenance and the associated risk with the risk associated with tube feeding. The management, if not properly managed, there are other infections and other adverse outcome could come from this intervention. Now, based on the findings, we have been trying. So these are all the questions that we have been trying to answer for LMIC setting. And this Global Cerebral Palsy Nutrition Program, which is an initiative of the Global LMIC CP Register that I'm currently working on. And this program basically is looking into what could be done, what could be the low-cost, culturally appropriate interventions that could be scaled up for children with cerebral palsy and their caregivers in low and middle income countries like Bangladesh. Now, I'm not going to talk about the other components, just the third component about the intervention. So we tried a few things. It's still in progress. We haven't found the magic bullet yet, but we are like in progress of getting to the final, like getting to the goal. Okay, so we tried a few different methods. So we have these smart CP centers, which we call in rural sub-districts of Bangladesh, and over there we have access to community rehabilitation workers and physiotherapists and a comprehensive team of multidisciplinary team via telerehabilitation. So what we tried is we tried to screen children, like use anthropometric measurements and identify children who are at risk of developing malnutrition, and then grouped them into different groups, like depending on their needs. And then we had a dietitian, we had speech therapists, we had physiotherapists, and a medical doctor who collectively would manage each individual cases, and plan customized intervention. It worked to some extent, like those children who had like good compliance. It improved the nutritional status in majority of cases. But unfortunately, this whole process was too complex for children with CP and their caregivers to follow. So what our finding was that the majority of caregivers would comply for the first 1-2 months, 3 months, but then in long run, they would not be able to follow those customized diet or the recommendations that's been made by the multidisciplinary team. And that is because they have too much competing interest. They need travel allowance to come to the center or access the facility. They don't have access to the food that we would recommend. We would recommend the low-cost food, but still it does not become in the priority when compared to any other complications that the child is regularly going through. Now, based on that findings, we then tried to find out what would be feasible for children and their caregivers. So this program, it's still ongoing, and we just finished the pilot phase, and we tried to understand what's the motivation for the caregivers, what they want, what information would improve their knowledge and practices, as well as child's nutritional outcome. Now, this program, Pushti CP, Pushti means nutrition in Bangla. So this program had 4 components, as you can see from this one: dietary modification, then feeding techniques and utensils, keeping food safe and clean, and finally addressing digestive and clinical issues. Now, this is more about education sessions supported by that multidisciplinary team I talked about, but now into community. So our therapist would go to the community, lead the sessions, talk to mothers, and then we'll get their feedback on what they need and to what like the dose and frequency of the intervention. Now, this is the outline of the intervention. I'm not going to talk about it. I don't think I have much time, but the information provided in those sessions, it's not like we developed something new. It's already there, but just need to find out what to provide and to what dose to provide. So these are a few useful resources I would recommend for those who are planning to do any education session or training program or develop a guideline for children with CP and LMICs. They could actually go to these sites. I can share these links later as well. Now, this in the left corner, we are now trying to develop, as part of GLMCPR, we have developed a manual called Where There Is No Therapist. So these, again, is no new science or knowledge gained, but these are basically using the existing knowledge and tools, how to make these resources more accessible and more adaptable for caregivers. So we are focusing on those. So this is a manual that we are working on and would be made available online soon. A few photos from the Push TCP trial. So these here, the mothers are actually developing the contents. So they developed a few checklists, then how to manage different food items and how to make a food plate from using their regular budget and like using their local materials in their households. Preliminary findings, this program was feasible. Like it was very easy to implement and was highly acceptable. The mothers loved it because they felt like they're getting what they wanted to know, but in a bit more organized way. And we did a very brief, like it was a 4 months duration period, and we had 8 sessions over 4 months. But then we did a pre and post assessment, and then we saw that it improved knowledge, nutritional knowledge, improved feeding skills. I mean, the changes in dietary intake pattern, like when we measured, it's not, it varied between the groups. Very interesting finding, and we are writing up the manuscript now. So basically, for the younger age group, we saw that the mothers actually implemented what they learned and they continued, which showed a better dietary intake pattern at the end of those 8 sessions. But then in the older group, like adolescents or young adults or GFCS level 3 to 5, those severe motor impairment kids, first they were very interested, but at some point they lost interest and they were more asking about what's the immediate solution, like because it was getting very difficult for them to daily manage their child with CP. We did not find any significant change in nutritional status, which is expected because only 4 months, as Mercedes explained, that even on 6 months, if there is a 0.5 kilogram weight increase, that's a win for children with CP in some cases. Now, very strong recommendation came from the families that we love this information. Thank you so much for all these techniques and all these training. But how do we access these good foods? And like by good foods, they don't mean highly high-priced packaged foods or something. Even for many families and in BCPR and who participated in this pilot study, for many families, just getting 3 different food items would be challenging. So a large number of these children were only fed milk or rice, milk or banana or something. So it's very difficult for them, and there were constant recommendation and feedback to include food voucher or supplementary feeding for, in the intervention package, like all in addition to all those education sessions and demonstration sessions. They recommended that it would be helpful for them if they could access food for their children. So these are two examples from Bangladesh. We are also doing some study in Ghana, and Mercedes is doing an amazing job in Argentina. So we are trying to, the main goal is basically to find out what would work. We are yet not there, but hopefully we'll be there soon. Now that brings me to the next slide, scopes for collaboration. We are very keen for your assistance, for your help. And if you are interested in joining this joint effort, please let us know. We would love to hear from your ideas, what you have been doing in your own practice, and how this could be adapted to the gold standard as ESV, as the standard guidelines have been demonstrating. I'm sure that we would be able to find that balanced line where LMIC-based resources available could be used to support children with cerebral palsy with optimal nutrition. Thank you so much. Any question, please feel free to ask. All right. Okay, there are, so please feel free to unmute yourself as well if you want to ask any question. Okay. Is there any association between malnutrition and motor function? Yes, Mahmoud. I think Mercedes, please feel free to add. But yes, studies actually have shown that malnourished children are less likely to respond to motor treatment, and it's the other way as well. With motor enrichment, like with therapies and others, it improves metabolic. It improves like with the motor intervention along with nutrition actually works best. Yeah.
Another thing to add is that is it being associated, but it's not like one is a consequence for the other.
No.
Motor function, higher the motor function CMS level, the higher the risk for malnutrition. But we don't know if the malnutrition leads to some complication in the motor function.
No.
But probably there are not many studies about this, but probably the undernutrition, the malnutrition also has consequences in the intellectual level of the children, because it is known that children that is well nourished has another development, but it has been not been studied in children with CP. And I think it's interesting to know also if these children with CP had been without undernutrition, what will he be like now? So I think it is something to be studied.
Thank you, Mercedes. That's actually
There's another question here that has there been any data collected where the other family members are also assessed for their nutrition status, not just the child with CP?
Yeah, thanks, Susie. Yeah, so in Bangladesh, we did one study as part of the Smart CP trial. We, as a subgroup population, we did collect information about the mothers and their food, the household food security level and child's nutritional status for almost 800 plus children with CP and their caregivers. Mahmoud, would you like to add any information to that? To the Smart CP trial, we have, because the idea was that to see whether there is any, how women, malnutrition in women and their household inequity could lead to malnutrition especially for children and women in low and middle income countries. So that was the idea behind that. We still have not analyzed the data yet. Sorry about that, Susie, but next time maybe we would have that information. All right. I think we are on time. 4 minutes to left. Mercedes, would you like to close the session and thank
Yes.
everyone?
Thank you everyone to be here. This was the first webinar about nutrition, so I think there was a lot of questions and participation. So I think it's an interesting topic to everyone. So if you also think that another idea or another necessity related to nutrition, you can also contact us and let us know, and we can plan another webinar. The one about the intervention is still on hold because we are figuring out, but we can plan other types of webinar related to this topic if it's an interest of you. And you are all also welcome. I know that a lot of people that are here are participating in CP registers in their country. So you are all always welcome to join the nutrition part of the studies in your population. Thank you very much. And thank you for all the nice words also in the chat about our presentations.
Thank you.
Thank you very much.
Mercedes, would you like to take a screenshot of all participants for our future?
Yes, if
So
someone else wants to.
yes.
Yeah,
Everyone, if you would like it's kind of a ritual. We turn on our cameras and we take a photo for all attendees for our website and future communication. Let's see how to do it. Yes, camera's turning on. Thank you. Let's wait for a few minutes.
Yes.
Nice.
Okay, so 1, 2, 3. Thank you very much, everyone.
Thank
And we
you.
will upload this webinar also. The previous webinars you can also check, and this will be uploaded soon.
Yeah. So please check out the JLMCPR YouTube page. So once for each webinar, we have recorded the sessions and which have been uploaded on the YouTube page. If you don't have the information, I can share it on the chat box for you. Give me a minute, please. There you go. All right. So here is here's the link to our JLMCPR web YouTube channel. Please subscribe for future information and videos. Thank you.
Thank you.
Bye.
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 Bye-bye. Thank you.